because of numbness, pain, and weakness in the upper limb, and most are managed conservatively at first, but almost all will at some stage benefit from surgical decompression. In my own practice, carpal tunnel syndrome is the most common, followed by cubital tunnel syndrome and pronator tunnel syndrome, which may surprise some of you, but actually I think it's an underdiagnosed condition. Okay, so these three are the ones I will talk about for endoscopic nerve decompression. So surgery is the definitive treatment for compressive neuropathy, in my opinion, okay, because nothing relieves the patient's symptoms faster or more permanently than a surgical release. I mean, if you got the diagnosis correct, it is. Okay. So the indications for this would be if the patient wants a quick, rapid relief. I don't bother with conservative management. If I'm confident it's a compression, I just go straight to offer release. Okay. Sometimes they try conservative treatment, they fail, or they have worsening symptoms and signs. They may have some objective imaging evidence of compression. Usually I will use either ultrasound or MR neurography for this, and physiological evidence of moderate or severe neuropathy. These are all indications for surgery. The goal of surgery, of course, is to get rid of symptoms permanently by removing all the constricting or compressive structures, restoring nerve gliding, and improving the course of the nerve on its bed as needed. Okay, so sometimes we need to transpose the nerve. Sometimes we also need to restore lost function, for example, in severe carpal tunnel release. So I'm going to talk a bit about the techniques that I use and compare to the traditional or the open techniques that I use for these three conditions. So first, carpal tunnel surgery. So that's a proper open carpal tunnel release, as Professor Rolf Birch indicated to me. He said all the open release you do nowadays is actually not the proper one. It's actually what is properly called mini open carpal tunnel release. This is the proper open carpal tunnel release. 7 centimeter incision, open up the whole carpal tunnel and proximal forearm fascia and expose the whole median nerve. I use this, yes, for cases where there's some gouty tophus or ganglion or tumor that may be compressing the nerve in the carpal tunnel, but only for that. Okay. The problem with this is the scar is very long, maybe hypertrophic or sensitive. Patients have pillar pain, there's a risk of injury to the palmar cutaneous branch, and the recovery time is quite long. That's a patient, not my patient, someone else who came to see me because of their sensitive scars. And that is the typical scar for open carpal tunnel release. So you may get a hypertrophic scar like that. This is what we normally do when we say open carpal tunnel release. Now it's actually mini open. Okay, so this is a much smaller scar, about half the size. Okay, it's still in the palm, unfortunately, so that causes some problems with the patient using the hand early. And the other problem is that to release the proximal part of the carpal tunnel and the forearm fascia, it's a blind procedure. You slide your scissors in and hopefully you release everything. So there's actually a high risk of incomplete release with this technique. Okay, so there's a shorter return to work, but still quite long. And that is the endoscopic carpal tunnel release that I use, which is described by AG in 1992. It's a single portal endoscopic carpal tunnel release. Okay, so you only have sub-centimeter. The incision I use now is between 7 to 10 millimeters, and it's out of the palm. Okay, at the proximal to the palm at the wrist crease, so you don't have any wounds in the palm. The patient can use the hand almost the next day for light things. We use a waterproof dressing so the patient can toilet themselves quite easily. So much faster return to work, grip and pinch strength returns quite fast, less incomplete release, but unfortunately the learning curve is quite steep. The video unfortunately is not playing. Okay, anyway, never mind. If you look on YouTube, there's a lot of videos on that anyway. Okay, so that's a comparison. So mini incision, same patient of mine. When I was a trainee, I did mini incision carpal tunnel release on one side. Later on, when I was a consultant, I did the endoscopic carpal tunnel release. Patient much happier with the endoscopic side. Okay. In case you're wondering if there's any evidence for this, or I'm just all my opinion, actually there's a lot of meta-analysis out there, number of them, that show that, and this is only the latest one that I've picked with endoscopic carpal release, you have higher satisfaction rate, better key pinch strength, 3 months, faster return to work, less scar complications. There are more transient nerve injuries, but they are all transient. There's no increase in the rate of serious nerve injuries or complications as compared to mini open or open carpal release. Now, of course, this is the latest development, ultrasound guided, ultra minimally invasive carpal tunnel release, where it's a percutaneous procedure guided by the ultrasound. You use a hook knife to catch the ligament and release it under ultrasound. But I don't do this because I'm not very good at using the ultrasound. So those of you who are very handy with the ultrasound, you might want to try using this technique as well. Again, some meta-analysis already, which shows that it has better symptom outcome, similar functional outcome, faster return to work, and notably, none of the series that we've published so far have shown any complications. Okay, so mean of 4 to 14 days versus 26 to 33 days for return to work. If you also need to do some kind of tendon procedure, in addition to your minimally invasive release, don't worry, we have that as well. So this is a minimally invasive palmaris longus abductoplasty, which is basically a modification of Kamit's technique. So instead of incising into the palm, we take a strip of FCR tendon as a free graft to extend the PL tendon to reach the MP joint. So next we go to cubital tunnel syndrome. So in cubital tunnel syndrome, there are several compression points, proximal and distal to the epicondyle, that need to be addressed. Not all of them are there, of course, but you need to look for them, and you need to release them if they are there in order to get a complete release. And this is particularly important if you want to transpose the nerve properly so that it doesn't kink or get compressed somewhere else after transposition. That is the way I was taught to do it as a trainee. Okay, so this huge whacking incision about 15 centimeters long to see everything and see the whole nerve fully. Okay. Fortunately, this guy Rima Hoffman came along and showed us his technique in 2006. And this is an endoscopic technique using a brow lift dissector and some long Metzenbaum scissors to create first you create a subcutaneous tunnel over the FCU muscle, release the FCU muscle fascia, then put the dissector under the muscle, and you follow the ulnar nerve down the forearm, and you can follow it up the forearm as well, and release it sequentially with the scissors. So this is open versus endoscopic decompression. Open release, now if I have to do it, it's much smaller incision, of course, but still about twice the length of an endoscopic release. And studies have shown that they have similar outcomes with less complications and better patient satisfaction with the endoscopic release. That's the scar for endoscopic release versus an open release. So how about transposition? Do we still transpose the nerve? I think there's a lot of evidence out there now that shows that there's no significant difference in the outcome whether you transpose it or not in most cases. Okay, and there's also very little difference between the different methods of transposition in terms of outcome. So I prefer transposition if the ulnar nerve subluxes after decompression, if there are osteophytes, or the nerve bed is scarred either from previous trauma or failed decompression. And transposition I prefer is a subcutaneous or subfascial transposition. Here's how we do it endoscopically. So we can make a slightly larger incision than the endoscopic cubital tunnel release, excise the septum. Then we use the scope to release the nerve completely, as seen here. Then we take a fascial flap from the flexor pronator muscles, and then having released the nerve fully, we can transpose it anteriorly and use the flap to create a septum by suturing to the subcutaneous tissue. So this is, after that we test the nerve gliding, make sure it's not subluxing behind the epicondyle, and we do endoscopic inspection for nerve kinking or compression. So I've I've had pretty good results for that. Moving on quickly to